Okay, so the obvious answer to that is no, but I'll just explain to you why it's obvious. So let's see, what do we get with chemotherapy? Jennifer kind of started like this too, but obviously I'm going to take a little bit of a different direction. So this is MD Anderson data, and this is a group that we call the FCR 300. And what's significant about this group is that we have very long follow-up on them and have really analyzed them very carefully. You note that in our trial, the complete response rate was 72%, a bit higher in a single institutional trial than the German trial. But I'll remind you with all the slides you saw today what the complete response rate was with the B-cell receptor inhibitors, even in the frontline setting, about 10%. So we're not getting complete remissions with those. Now, do you need complete remissions? I don't know about you, but if I'm the patient, I'd really rather have no disease. Not only that, but we know that as long as you have circulating lymphocytes, they mess up the T cells because the crosstalk between CLL cells and T cells is very abnormal. And it's very clear that if you get rid of cells or you get into complete remission, your infection rates go down. And the other important point is if we're actually trying to get rid of the disease, it seems a bit unlikely that's going to happen if we don't get a complete remission. So yeah, I think complete remission is still pretty important. But you know, that's, as people like to say, that's MD Anderson data. Okay, so let's look at some randomized trial data here. This is again the German CLL 8 study. And they showed, again, just adding antibody to the chemo, you get a much higher response rate, and you get better complete response rates. Now, Jennifer showed you this same curve, and she came to a slightly different conclusion than me. What I want to show you is that, number one, the median progression-free survival is 5 years. Okay, 5 years. I don't think we actually have seen any data that goes out to 5 years with any of the drugs she just showed you. But here, we're getting remission durations of 5 years. Oh, and by the way, these people are actually not taking any pills. They are off therapy and in remission. The other point, and I'm going to come back to this, is that the longest follow-up out here is about 5 or 6 years. So the real question is, well, what happens after that? And that's the important point I'm going to show you. The other thing she didn't mention is that FCR is, in fact, the first regimen that's ever been shown to have a survival benefit in CLL. Survival as in people live longer. Okay, so I've been touting the benefits of FCR, but am I willing to admit that maybe it's not for everybody? Yeah, okay. I already told you this morning, it's clearly not for the 17p patients. So that's a no-brainer. Everybody would agree on that. We need alternate regimens for those patients. Now, mind you, if you look at the upfront setting, those are about 5 to 10% of upfront patients, although, as I told you this morning, it's a very common clonal evolution. It's very common in refractory patients, but it does represent a minority of upfront patients. But I would certainly concede that this is a group where let's get away from chemotherapy. The other group that people sometimes say can't take chemoimmunotherapy are older patients. Well, is that really true? In the CLL8 study design, in fact, there were patients over the age of 70 who went on that trial as long as they met this criteria. So they had to have a good creatinine clearance, which makes sense because remember that fludarabine is renally excreted. So in fact, if you take most older people who don't have a normal creatinine clearance and gave them standard dose FCR, you would in fact be overdosing them in effect. So I think that that was a pretty reasonable eligibility criteria if you're going to use a fludarabine-based regimen. But they also had to have a SEER score, which again is a comorbidity score, less than 6. So it's admittedly a somewhat select population of older patients. However, if we do select like that, what we find is that in fact there's no difference in toxicity for patients over the age of 70 who got FCR compared to those younger than 70. So it is not true that all older patients can't take FCR. And again, I think we all know that age by itself is probably not enough, but we have to take into consideration renal function and comorbidities. But the point is, if you fit these criteria and you were over the age of 70 and you got FCR, you did just as well as the people who are younger than age 70. You'll note that there's not one single significant p-value in that last column. Now, what percentage of older people is this? Okay, I actually wasn't sure. When I saw this data presented for the first time, I said, well, that's all well and good, but you know, what percentage of people over 70 are really accounted for come into this population? So I actually did a survey. I looked at my own clinic, and I looked at all the patients over 70 I saw in 1 month, and there were 14. 3 were over 80, and I will say over 80 was not allowed on the FCR8 trial, CLL8 trial, so that threw them out. That was 11. And only 4 met the creatinine clearance. So I was already down to 29%, and that wasn't even counting the SEER score, which I didn't calculate because I didn't know how. But a lot of them had significant comorbidities, meaning that it would have been even less than 29%. So I'm also willing to concede to some extent that most older people are not going to be ideal candidates for FCR, although I would still raise the point that a lot of the toxicity that we encounter when we try and give it to older people is based on the fact that they rarely have a normal creatinine clearance, and we really are overdosing them if we don't treat them with decreased doses. And I will routinely use FCR in older people, but I will routinely dose reduce it. But okay, you could go either way on older, and older is, of course, somewhat in the eye of the beholder. This is back to MD Anderson data, and this is the FCR 300. And so what you can see now is now we're talking about real long-term follow-up data here, which you haven't seen in one slide that Jennifer showed. Okay, we're talking, if you notice here, slides that go out 11, 12, 13, 14 years, all right? The blue is the PFS curve. Look at this. There is a very clear plateau on that curve. Now, I will admit that that plateau comes in the minority of patients, right? Over 50% of the patients have relapsed. But these are people out 10, 11, 12 years who are still in remission, I will say in many cases MRD negative. Now, are they cured? I don't know. Frankly, I don't know. But I do know that it would be really nice to take treatment for 6 months and be out 14 years with no evidence of disease. So then the question becomes, can we identify them? Because, yeah, we can all agree that we don't want to give chemo to everybody, but could we try and figure out up front who might be on that plateau, and then maybe not throw out chemo in that population? And I think to some extent we can. So this is MD Anderson data looking at MRD negativity. So you can see that about 3/4 of our patients who achieve a morphologic CR, MRD negative, and much less in the PR. This is using the old criteria for PR, where if you were cytopenic, you wouldn't be a CR. Those patients would now be called CRI. So some of these PRs that were MRD negative were actually CRs, but with residual cytopenia. Does that matter? Well, you saw the German data this morning where it matters significantly, is a very important predictor of outcome. And in fact, we can show you the same thing. So this is, and you might note this is not the 12 or 14-year data I showed you, because we didn't, in the FCR 300 early on, we didn't have MRD analysis. So this data is admittedly of shorter follow-up, but the point I'm trying to make here is that, yes, just like in the German data that you saw this morning, if you become MRD negative, that is really, really important for a good long-term PFS. But one of the problems with MRD negative is you only know that after the treatment, right? And what we would really like to do is identify these people up front. So then the question becomes, well, not only what predicts for long remission, but maybe as a surrogate, what predicts for MRD negativity. And we have looked at a multivariable model, this is Bill Weirda's work, looking for what predicts for bone marrow MRD negativity. And not so surprisingly, what is important? Mutation status and FISH. Now, you might say, well, where is 11q? 11q is always subsumed by mutation status. And the reason for that is approximately 90% of patients with 11q deletion are unmutated. There is a very, very tight correlation between being 11q deleted and being unmutated. And unmutated is more powerful than just being 11q. So 11q will almost always be subsumed in any multivariate within the mutation analysis. So it doesn't mean it doesn't matter. It's just that once you say mutated, you're basically excluding the 11q. So if you're mutated and you have trisomy 12, which is good, and you don't have 17p or 11q, you're highly likely to be MRD negative, meaning you're highly likely to have a long PFS. And this is an example. This is, again, the FCR 300, where we don't have a lot of MRD data, but we do have mutation status data in most of them, although the green are the unknown. And again, we see this beautiful plateau even higher up now because we're selecting out the mutated patients, and they're the ones that are comprising, as I told you early, a lot of the patients that are on that long-standing plateau. Well, we're not the only ones who've looked at trying to predict who are the people that are going to do particularly well with FCR. In fact, the Germans presented on this at ASH in 2011, and they looked at the data from the CLL-8 trial, that randomized trial of FC versus FCR. And what they showed, which was very important for predicting early progression, or the flip-flop of that would be long-term remission, was the MRD, which it is, and then look at this, 17p deleted or mutated or unmutated. So exactly what I showed you. Now, the reason it's the opposite of what I showed you is they're looking at what predicts for early progression. I was showing you what predicts for long-term remission. But notice that they came up with exactly the same factors, namely the FISH and the mutation status, and that's pretty much all you need. The MRD definitely helps, but as I said, we're trying to sort these people out up front. And when they show their data, you can see the progression-free survival for what they define as high risk versus low risk. And again, look at the progression-free survival curve going out to about 6 or 7 years with very few relapses if you were in the low-risk group. So I would just like to conclude by saying that think about it. If you're the patient, you need treatment, you're mutated, you don't have an 11q or 17p, would you like to go on a pill that you have to take, as of now, forever, where you may develop mutations in the kinase that pill targets and then become resistant, where you don't know how long the remission's going to last, where you don't know what the late toxicities are going to be? Or would you like to be inconvenienced and maybe not having a great time for 6 months and then be done and be on this curve at 13 years later? I know which one I would vote for. Thank you for your attention.